Welcome to Frontline Nursing, a NurseMinder production that gives you an insider's look into the daily life of nursing from those who are working on the front lines. Whether you're considering nursing as a profession, you are a student studying nursing, or maybe a nurse in transition looking for a new career path, this will give you some behind-the-scenes information to help you guide your career. Today's episode is all about working in a variety of healthcare disciplines in acute care settings. So get those note apps, pens, and papers ready because it's going to be another good one. Today on Frontline Nursing, we are joined by Huma Khan, an LPN who works in a variety of areas such as thoracics, women's health, vascular, and general surgery. Welcome to the show, Huma.
Hi, Tammy.
Hi. So let's just get started. I always kind of like to get background information about what brought you to nursing in the first place.
Sure. I actually had quite an extensive family history of illnesses, so I was in and out of the hospital quite often with my families, and this was back home in Pakistan, so of course nursing is a bit different. And then when I was in high school, I got to do a little shadowing day with when they came to our school to introduce nursing and such, and they had discussed the LPN to RN path because at that point I wasn't sure if I wanted to do 4 years of schooling. So some of the girls recommended doing the LPN program. And so now way I can transition into the RN role if I wanted to later on, which is, as you know, I'm currently doing.
Yeah.
But yeah, and I got to volunteer at the hospital, so I really liked the interactions. I was volunteering in the ER at the Northeast Community Health Center and at the Alex as well, and I really loved the elderly population. I got to interact with patients, kind of get to know them a little bit more. Hear their stories, so it was just nice to see that. And then just with my own family experiences, I saw good nurses, I saw bad nurses, and it kind of drove me towards becoming a nurse.
So did you have any experience with nursing in Pakistan, or was it when you came to Canada that you first had that exposure?
When I was younger, I was in and out of the hospital with my family back home in Pakistan, so never really in Canada per se, but I did. The opportunity kind of popped up, and my dad had even mentioned like, oh, you could always go into nursing, something that you always want to do. I wanted to do something in the healthcare profession, but I wasn't sure it was between, going back and forth being a social worker or a nurse. And in the end, I guess nursing won.
Well, and it certainly sounds like it won when I look at your resume so far.
Yeah, for sure.
Yeah, that's pretty amazing. I think a lot of people come into nursing because they have been either personally touched or their family lives have been touched by healthcare, and they see the work that we do, and then they find that they're kind of drawn to that profession of caring and helping and nurturing.
For sure, because you can see the effect it has, when you have a good nurse, and certain things they say or teaching they provide makes a huge difference and kind of makes you see things a little bit nicer, because docs come in once in a while, let you know what's going on, but it's the nurses that you interact with on a regular basis, right? So that's what I really liked when I had my family experience, being on the other end of it. Mm-hmm. And I wanted to do that for someone else. So yeah.
Now, did you get to shadow in the school? You said that was in high school?
Yeah.
And that kind of sparked a deeper interest for you in nursing when you got to do that?
Yeah, it wasn't necessarily really shadowing. It was more so of kind of her walking me through what her day would be like, because I'm sure a lot of people have the question, oh, is it kind of like what the movies show or what the TV shows, So it was more so of that. And then one of my other friend was considering nursing as well. So it was kind of nice to kind of go back and forth. And her mom used to be a nurse as well. So she brought that input as well and worked in the hospital. So, just all those things in combination was encouraging to go into nursing. So, yeah.
Yeah. And so what was your final verdict? Was it like the TV shows you saw?
No. 100% no.
Nothing like it, right?
No, definitely not.
No, they showed the doctors doing everything that we do. That's the one thing I always tell my husband. Anytime we watch a TV show, I'm like, you see that doctor taking the blood pressure? That's my job.
Or the patient getting up with the doctor. I actually had a doctor who had asked me, it was her mom who was hospitalized, and this was in like a couple of years ago, and she asked me, she was like, hey, I would help you how to get my mom up, but I have no idea. You teach me and I'll give you a hand. So at that moment I was like, see, it's not Grey's Anatomy.
It's definitely not Grey's Anatomy.
No, definitely not.
Yeah. So when you went into nursing school, did you have a particular specialty in mind when you started, and did that come to fruition at the end, or did that change as you went through?
I think I always knew I wanted to do something in acute care, but I wasn't really sure because I didn't have the exposure. And because I did volunteer in the ER, I saw how fast-paced it was, and you got to see quite a few different things. So I did want to, and my aim still is to try and get into the emergency at some point. But I knew I wanted to stay in acute care, even just with doing the courses and such. I knew I didn't want to do postpartum, and I knew I didn't want to do medicine. Just acuity and surgery, it was intriguing, and to know how different things kind of play into role in how, and it's not just about, fixing the now, it's just going deeper. You also have to consider the mental health aspect of it and why this thing could be affecting this thing type of thing, right? Like lifestyle choices and how they can affect your recovery post-op and even your mindset as well. So I think that's what was intriguing to me.
Awesome. So let's dig into the surgery side of your experience. Sure. So we've got the vascular surgery.
Yep.
I kind of forget what's on your resume now. I got to go back. There's so much there. Thoracic. So that's also another surgical floor. Okay. And then women's health. Is there any surgery in that one as well?
Yeah. So in women's health, it's oncology. So a lot of gynae oncology, urology surgeries as well. And then, of course, the typical hysterectomies, oophorectomies, albendectomies, all those sorts of things. And then a little bit of general surgery, because sometimes we have the total exonterations. They have colostomy, ileostomies, curved ileostomies, and all that stuff, right? Ovectomies, things like that. So a little bit of surgery in that as well. But thoracics has just been pretty much, I think, the most acute I've had so far at this point, I would say.
Was thoracics?
Yeah, I think thoracics in acuity, thoracics would definitely be, I found the most challenging, just because there's so many different things you need to consider. And I think part of that is because you have to be so careful in what patients are eating, how they're sitting, how they're mobilizing, what goes in, which tube, so all those little things play, and you have to, that critical thinking, because anything, your ABCs, and usually your A's are where it goes wrong with thoracics, right? So airways are always complicated. So
you're right at the top of the food chain there.
Exactly. So when you think about it, I'm like ABCs, I'm right at the top. So yeah.
And B is probably a close second,
Oh, for sure. For sure. Yeah, it's always A's, B's, and then C, not so much. But at that point, you'd hope someone comes in and helps you.
Is thoracics the first place you started after school, after you graduated?
No, I actually had been hired out of preceptorship in women. So I had worked there for about 3.5 years before I switched over I took a temp line on thoracic unit.
Okay. So I want to go back then to your first, if you go back to when you were a student, you were starting out as a new nurse, all those questions you had. I tend to begin with the new nurse questions, then we'll dig into the other stuff later.
Sure.
What were some of your biggest fears in being the nurse?
I think the biggest fear was time management for me and just not knowing the answer. I mean, I know you can always rely on your team to ask questions and stuff, but when you're the nurse, as you say, family members expect you to know the answers. Patients expect you to know the answers. If they have a question, they expect the answers right away, not for you to, have to go out and ask a nurse every 5 minutes, hey, what do I say in this situation? Or even just explaining certain things, explaining procedures, why they could suffer some complication. It's not part of our role, but I do get asked those questions quite often because, when surgeons are explaining, it comes in one ear, goes out the other ear because you're so anxious about surgery and such, right? So I think for me personally, that was the hardest part. And I knew I was going to have issues with time management and just figuring out, where, okay, I need to take a break. These things can be pushed back or, to next shift. Things like PICC line dressings or, just a daily dressings, right? Like they can always be pushed back. So I think that's what I found the hardest for me when I first started nursing. And I think it definitely develops with time as well, right?
Yeah, so be a little gentle on yourself.
Yeah, exactly.
It's hard to do that when you're the new nurse because you think you have all these responsibilities. You need to prove your weight and that you're capable. Yeah. It sounds like prioritization was one of the skills you used to kind of decrease the stress you have on your own self for time management.
For sure.
Back some of those dressings.
Yeah.
Are there any other tips you have for someone who's maybe struggling or worried about time management that you found helpful?
For me personally, that's why I have my organization plans, because I used to come in half an hour early before shift just to kind of get rid of the anxiety, get my assignment, write everything down, anticipate what I need to do for the shift, This is before I even get reports, so I kind of know what we need to do, what the protocol is on the unit as well. And my organization sheets, I write everything down. So for example, if anything's highlighted, it means it needs to be done on my shift. I have a sheet for ins and outs, so I know that I need to check this, and this at the end of the shift. So that just helped me stay organized. And then if I was really busy, I took one look at my organization sheet and was like, oh, okay, I need to do this type of thing. So I think that
throw it in the garbage and say, well,
sometimes it happens. Sometimes that's what happens. But when I had that sheet just to kind of refer back to, or if a patient had a complication but like I had my history, I had everything I had given them on my piece of paper that I've been carrying around all shift, is very quick for me to kind of look back at and just kind of, hey, this is what I have given her, this is what happened, and then this is, what changes occurred, right? So I found that helped me quite a bit with my time management, and that's why you see such a variety in my organization sheets as well, just so I'm working less, right? Work smarter, not harder.
And you work in a lot of different places. Each place requires a different style of nursing or a different approach to nursing.
Exactly, yeah.
Yeah, I should have wrote down my question when it came through my mind because it's gone now. I had a good one to ask you. We'll have to come back to it if it comes back to me.
Sounds good.
This happens almost every interview because I get so drawn into the conversation. I'm like, oh, I'll ask that later, and I never come back to it because I forget it.
Oh no.
I know, we're talking about time management. It's gone. All right, we'll move forward then. What were some of your biggest struggles just in general, aside from time management, just in general as being a new nurse?
I think it was the fear of doing wrong, per se, because I was always so anxious, triple checking everything, making sure you weren't doing the wrong, giving the wrong medication, taking the wrong step, taking out a Foley that didn't have an order. And I feel like sometimes with some older nurses, you do get that pushback. Oh, you can take the Foley out, I'll get a cover order. But that's not necessarily what they teach you in school. So
there's always a bit of I always keep using these words, always. There sometimes is a disconnect between what you're taught in school and what the practice is on the floor.
Exactly.
And finding your voice to advocate for, well, this is the best practice today, which changes.
For sure.
Not that the fault of the nurse on the floor has been working for 20 years. It's hard to keep up with all those changes, and we rely on those new nurses coming in to keep us current.
Yeah.
So that could definitely be an issue sometimes.
Yeah, and I found that a sense of just having to prove myself, even because I do work different floors in postpartum as well. So just kind of having to prove myself to the third floor staff because they didn't know me, and I was a student on second floor. So just kind of proving that you know what you're doing, you're capable of taking care of these patients. No one has to kind of watch out for you or follow you around type of thing, right? So I think that was some of the stuff that I struggled with, and I think I've continued to struggle with that in new positions as well. When I went on thoracics, I felt like I needed to prove myself, for them to accept you in a sense. But I don't know if everyone else has those feelings, but that's what I've found.
Is some of that coming from just your internal worries and fears, or are you getting messages and feedback from nurses that you're not accepted until?
I think it's just because everyone has a group, everyone has people that they're close to when you work for a certain period of time, and it's really hard to kind of be the new person on the unit. You don't know everyone else has to know one person, whereas you need to know everyone, like 10, 12 different nurses, right? And I think part of that was just my own anxiety and being in a new place, and it's a different building, policies are different, right? So definitely I think it's more internal than external, and I never really received any feedback from other staff, and they would always question me. I had lots of them say, oh, how long have you been on the unit? And I would say, oh, like 2 months. Oh, I would have never guessed type of thing, right? So I think it's just more so internal than anything else. But I think that's just, it is what it is.
And I think that's a real common worry and concern that people have, especially when you've gone to so many different floors and you've transitioned a few times. It comes to the forefront more often than someone who stays on the same unit for their whole career.
Exactly. I mean, definitely women's is definitely more comfortable for me. Like I can go back, pick up after 4 or 5 months, and I'm more comfortable there. And it is what it is. That's just a comfort, right? And that's why I wanted to leave and try something else, because I didn't want to get too comfortable to the point where then I couldn't leave, right?
Yeah. Do you still go in 30 minutes early to get your information out, or have you adapted and you've gotten a little bit more comfortable with the process?
I sometimes, depending on what I know, like if I've been there the day before and I know I'm going to have the same assignment the next day, I won't necessarily go in very early. I'll maybe go in like 15 minutes early, so then I'm not rushing to grab everything and not holding up the next shift. I don't necessarily go in half an hour early. I don't remember the last time I did that. But it's just, if I've been off for a couple of weeks, I don't really know the patient, or, if it's been quite a few days, then I'll try and get there about 20 minutes early, just so I can have the assignment, sign in, go into VAX, and trying to remember VAX as well is another story.
Yeah. And I wanted to ask that question because I think it's important for our listeners to know that when you start, you're going to do some things that modify from what other practice is. So I used to go in 30 minutes early as well, because I needed to write everything down.
Yeah.
Then as you become more comfortable in your area, you know the things that you need to write down, the things you don't need to write down, and you can start to thin your own sheet out.
Exactly. Yeah. And that's why I have the sheets as well. So then that way, as I'm getting a report, I'm writing my stuff down rather than going in half an hour early, writing everything down when the nurse is going to basically tell me the same thing and report anyway, right? But it's just, when I was new, I wanted that reassurance that I had everything that I needed to for the shift to start off on a good note.
Yeah.
Mm-hmm.
So in women's, what was the typical population? I can't remember if we covered all of that. You did talk about postpartum.
Yes.
And gynae surgery. So what would be some of the common things you would see on those floors in terms of diagnoses, treatments?
So a lot of hysterectomies, of course. Oophorectomies, hysterectomies, DNCs after miscarriages, quite often. Even those who've lost pregnancies, ectopic pregnancies. So lots of procedures for that. Even sometimes we'll get patients from other units for biopsy, cervical biopsies, that they can come and get it done in our assessment room. And then oncology as well. So even if it's ovarian cancer, anything like that, uterine, cervical, anything like that, complications. So small bowel obstructions, end of life care as well. So sometimes we've had a couple of cases, I believe, of medical assisted in death as well on the unit. So lots of different variety, and we'll get patients from cross cancer as well if they're under our oncologist. So a bit of that as well.
What I hear in every one of those diagnoses is a lot of emotional needs as well. So it sounds like not only are you task focused, you've got the surgical piece and the care activities you need to do in a day, but that with most of these patient population, that there's probably a significant amount of emotional care that you're providing to them as well. Would that be fair?
Yeah, for sure.
And what kind of strategies or how have you adapted to that role in nursing? In school, we don't really talk about that a lot. We don't really get into that a lot. And then you found yourself working in places where their bodies are being changed and modified, or they've lost something, and that sense of their own self-esteem and worth. How do you deal with those?
I think part of it does come with experience, just knowing your patient as well. I've had patients who don't want to talk about the diagnosis, or I've had patients that all they want to talk about is the diagnosis. You want to sit down with them, even the nonverbals. Like I had mentioned to my preceptor as well, some of the nonverbals. I noticed one of the patients had told me, when nurses stand with their arms crossed in front of me or over me, I feel powerless. So I keep that in the back of my mind. I always make sure I sit beside them or kneel, and then we're at eye level, and I speak softly. I give them time to kind of get their thoughts together. I always make sure, I think the power of touch, you don't realize it until you've been in that situation where that's all they're craving. I've had patients who don't have any family members or refuse to have family members come in, and they you are their family at that point because they stay with us for months and months and months, right? So I think part of it is just knowing your patients. I always go in, avoiding, the making jokes and stuff like that until I can see with the patient where they're at as well. And I think part of it is just kind of debriefing as well. Like I've always tried and debriefed with and I've cried with patients. Like I'll step out of the room. If I need to cry, I'll cry. I mean, I don't want to be to the point where they're going to have to take care of me. But I've shed some tears with patients. And I think that just shows that you're human as well. You're affected by what they're going through. So I think it's just based with my experience, just with time as well. It's not something that, for sure, when I first started, I was more concerned having those patients because I didn't know how I could interact with them, what to say. I never wanted to say the wrong thing. But I think if you apologize and just are mindful of what's going on, how they are. Just keep in mind, it's about them, it's not about you. I think that really helped me in the end.
And I know definitely in our North American culture, we don't talk about feelings a lot. So I don't know if there was a difference with and I don't know how much you're rooted in the Pakistan history and your culture there, as if there was a disconnect with those two pieces, or if it just was a natural, they kind of have the same, I'm trying to say.
No,
I talk about feelings any more or less than we do here in the North American culture.
Yeah, I think you do bring up a good point, because back home in Pakistan with abortions and stuff like that, nobody even says the word abortion. And I can definitely see that in the clientele as well. We've had some patients that don't want to see baby, don't want to hold baby, absolutely nothing, as if nothing happened type of thing. And I do understand where they're coming from that cultural aspect. And we don't really talk about death. We, just being more, yes, we know death is approaching, but nobody ever wants to talk about it. Yeah, exactly, right? It's almost as if you say it, it becomes a reality for a lot of people that, oh, it's inevitable. You can't really stop it from happening, right? So there's definitely a shift in the cultural aspect of it for me personally as well. But I've definitely geared it more towards because I've basically been in Canada for 14-15 years now, so I've more adapted to that culture than I am in Pakistan, and I'm sure it's going to be different when I go back and use some of these best techniques, like the touch as well. We don't really do that. Eye contact, we don't do that, which are big things that I find patients really appreciate, right?
Mm-hmm.
So definitely a disconnect in the cultural aspect of it, but I think you just adapt, right?
Mm-hmm. I just want to clarify, you'd mentioned that some of your patients stay with you for a very long time. I'm assuming that's the palliative patient and not the hysterectomy and the oophorectomies.
Yeah.
Just for those who maybe don't know.
Yeah, unless there's a complication, it's usually our oncology patients that will come back, usually with small bowel obstruction or just failure to thrive sorts of things, right? So
yeah. So with all the emotional nursing that you do, how do you keep yourself feeling refreshed every day to go back? I know you're in a different area currently, but we'll just kind of go back to that because it was your first area that you worked in primarily.
I think, like I mentioned earlier, just talking about it with other nurses on the unit, I found quite helpful. And then I try my best to kind of leave things at work. When I come home, I try and do certain things that, like, I really like yoga, I'm really into sports. So I'm trying to do those things that kind of get my mind off of it, because I found when I first started, I found that I would dwell on it. Oh, like I lost a patient. And there was a patient that I was really close to that I had known as a student. And then when I started working, I had her as a patient, and she had deteriorated quite a bit to the point that she didn't know who she was. She was in pain all the time. So when she passed away, it did really hit me hard. But over time, I did, like, spiritual care was amazing. I got to talk to some of the spiritual care nurses, and just with the patients that we get, I think it's been really beneficial just to talk to other staff. We get a little debrief. We kind of shed some tears. We actually had a really bad year, and the manager let us light a candle for and think about a patient that we wanted to light the candle for.
We all just beautiful.
Because we had a really rough year. I think it was last year or the year before. So that was really helpful, just to kind of debrief and get things off of your mind as well, right?
Yeah, and kind of give the honor and the respect that you feel like you want to do in that moment. That's beautiful.
Exactly. So I honestly found that very beneficial, and I try and do it. And sometimes just talking about it as well, right? It helps quite a bit.
Mm-hmm. Yeah, and I agree. I'm a talker too, but not everybody is.
Yeah, not everyone is, and you just have to figure out what works for you, right?
And my husband's not a talker, so that's why I need you guys. All right, so let's divert now into thoracics. Quite a deviation from women's health.
Yes.
Talk to me a little bit about thoracics and what your typical population is there and the things you got to see that were different.
So I think it was just shocking with how many chest tubes were there, because prior to, right?
Yeah.
I remember the first 2 days I had a guy with 4 chest tubes, 2 on one side, 2 on the other side. And I was like, how are you alive with 4 chest tubes?
No, we think that they can't possibly be.
And he's this little man as well, skinny as a bone. And he's got 4 chest tubes coming on. And he used an epidural, Foley, all that stuff, right? So anything you can think of, he had it. I think it was just
And I think
terrifying.
it's important to say that this is unit nursing. This is not ICU. This is not
Nope.
emerge. This is on the unit where,
Yeah.
and for those who are new to nursing, to be preparing that it's not going to be just oxygen on the face. There's actually
No.
going to be tubes and lines and a lot of things going on with your patient that you have to manage.
Exactly. And you have to, there's a lot of, I was going to say, just kind of figuring out what's going on, what's wrong, because you got to monitor the chest tubes every hour, figure out if there's an air leak, where the air leak's coming from, if it's draining from the site, how much is the output, how's their breathing, if they've got emphysema, all those sorts of things, right? Like, why do they have a chest tube? Do they have a pneumothorax? Do they have a hemothorax type of thing? So it's just a lot. Emphysema, yeah, right? So it's just like a lot of things that you need to take into consideration. So it definitely was more critical thinking than I was used to in women's because, like I had mentioned earlier, it was ABCs, right? So in the back of my mind, I was always going through ABCs. And one of the big thing I actually, when I was your student in MedSurg, was doing the safety checks. So oxygen suction, it plays a big role in thoracic. So first thing I would do when I go in was do my safety checks as I'm talking to the patient, have the blood pressure going. But it's definitely shocking in comparison. I didn't expect it to be, I knew it was going to be acute because of it is being thoracics, but I didn't expect it for them to have so many tubes, like an NG tube, a J tube, they're on 2 feeds and they've got a Foley, all these sorts of things, right?
Yeah, there is a lot to consider.
Yes, very much so.
All the tuberculosis, do you get those on your floor as well, or that's maybe medicine, I suppose?
Not necessarily. I don't think I've had a patient with TB. It's just more so of esophagectomies, so esophageal cancers, all sorts of different, or lots of gen surge patients as well on the unit because it is overflow for gen surge.
Yeah.
But majority of it has been, I think the heavier patients are definitely the esophagectomies. I know we had a guy who they used part of the colon as part of to replace the esophagus, and he was there for how long? I was there for 5 months, and he was there for 5 months, didn't eat, didn't drink, and peel the entire time. So
wow, that's an extensive surgery. Was it complications?
Lots and lots of complications. He kept having to go back and forth. He went into respiratory rest multiple times, so back to ICU and to us. So he used to joke and say, I've seen every bed on the unit, because he'd been pretty much on every bed on the unit at that point. Yeah. So lots of complication from the surgery just because of how critical it is, right? So, yeah.
What's the typical length of stay, do you think, for the patients in thoracics? Is it like less than a week, more than a week?
It depends. So with our esophagectomies, I would definitely say it's been over a week, unless I don't think I've had a case where they've gone home before a week, usually months or so. With our other ones who are just there for a wedge resection or a biopsy or pneumothorax, hemothorax, even our empyemas usually stay a little bit longer, but they can certainly go home with a certain type of chest tubes as well. But with some of them, the stay can be as little as 2 days. So, yeah.
Not quite as a high turnover, because it sounds like there'd be a bit of a mix of all those, but definitely within, a set of shifts, you would see some new patients in there.
Definitely. There's been days where I had 4 people with chest tubes. Everybody's clamped in the morning. They all go for chest x-rays. 6 hours later, they go for a chest x-ray again to see the progress. The chest tube's out, you can go home. So I've had to discharge 4 and gotten 4 admissions as well on a shift. So it's definitely a lot more high turnover than what people would think, because people always assume it's part of like medicine because they're on 2 feeds and such, right? But you do have those patients who are there for simple things like wedge resection or arthroscopy or, like little things like that, right? Which
can you believe that you're saying those are simple things?
I know.
When you were a student.
I know, that's what I was just saying. That's what I was going to say. I'm like, they're not little to most people, I guess. They're little things.
I love the perspective change. You've gone from being a student studying all the stuff and thinking, oh my gosh, that's intense, that's wild. And now you're like, it's just a minor thing.
Exactly.
It's fantastic.
It is, yeah. I know before I used to be terrified of chest tubes. Now I've had to, even in my preceptorship at the moment, they had a chest tube, and it was an emerge nurse, and she's like, I heard you know chest tubes. Can you walk me through it? So I went and did the assessment with her. So it just goes to show that your experience will apply at some point. And, even if you work emergency, doesn't mean you know everything and you've seen everything.
Absolutely.
Yeah.
My first time on the floor as the nurse, in all of my 4 years, because I did the bachelor program, in all my 4 years, I never had a patient that I had to bed bath. I never had a total care patient, like where I had to physically roll them. I could help them and stuff like that, but I didn't have to do it all.
Yeah.
And so I kind of felt a little embarrassed when I was finally the nurse and I had this total care patient. I'm like, I don't know how to dress them. I don't know how to roll them.
Yeah, exactly. But that's the thing, right? Once you're used to it, once you've done it once, it's good.
Yeah, and I like that you brought that up, that even though she was an RN, she's from Emerge, the education and the initials behind your name do not preclude that you are foregone knowledgeable in these particular areas. Like everybody has experiences, and that's what prepares you to nurse. And so if you've never seen a chest tube, or if you haven't worked with one in a few months, they're intimidating. You want to make sure, because airway, as you said, top of the list, you want to make sure you got it right. And I think it's fantastic that they recognize your experience and expertise and brought you in on that.
Yeah, and it was more shocking because, I mean, at this point, I'm a student on the unit, right? So for them to kind of ask for my help, even with NGs, because I said NGs and tube feeds with the new machines, I said I have lots of experience with that stuff. And a lot of the staff were willing to ask me for help, which was eye-opening for me as well, because I didn't expect that, which I was more worried about when going into the preceptorship, that nobody was going to consider my experience and they were going to treat me like a brand spanking new nurse, right? So it was definitely nice to see that.
I want to thank Huma for sharing and being so open about her experiences from Pakistan to Canada, the fears of being accepted and time management and everything in between as it relates to nursing on multiple different floors. Now, if you would like to hear more about After the Taping, join Huma and I at frontlinenursingpodcast.com and become a member today, and you will get a free quick start pack with your membership. Huma is going to be sharing how she has navigated the transition from LPN to BN while working full-time in just 2.5 years. Very exciting. Join us there, and until next time, if you have a story you'd like to share, email me at info@tammydunnett.com and make it a great day.